Hello, everyone. Welcome to the Journal of Clinical Investigation series, Conversations with Giants in Medicine. I'm your host, Ushma Neal. I've been wanting to interview Dr. C. Ron Khan of the Joslin Diabetes Center and Harvard Medical School for some years now. But given that we are about to commemorate the 100th anniversary of the discovery of insulin, it seemed extremely fitting to interview the physician scientist who was so central to helping us figure out the mechanisms of action of the insulin receptor. Thank you so much for joining us today, Ron.
Thanks for giving me this opportunity, Ushma.
So I would love to start with hearing a little bit about your family, what you were like as a kid, where you grew up.
Yeah, well, I grew up in Louisville, Kentucky. My father was a merchant. He was actually born in the Ukraine in Russia, came to the United States at about the age of 12. My mom was born in the States, but they were a couple that got married in Louisville, Kentucky, and my brother and I were both born there. I went to the public school system there. I had a couple of very cool friends, actually, one who became quite a successful artist, and he and I would hang around. We had an old Model A Ford that we would drive around. As I tell my granddaughter, was kind of a chick magnet, and that was kind of part of my social life. But I always was really interested in science, and my parents wanted, actually, both my brother and I, hopefully, to be doctors. My brother became a PhD, and I became an MD, but we both did biomedical research, and I think my parents were very proud of us. It was great growing up in Louisville, and I still have very fond memories of that time.
Now, by my calculations of reading your CV, it looks like you went to the University of Louisville where you majored in chemistry, but you graduated by the time you were 20. So were you an extremely advanced student?
Well, I guess I would like to think so, but actually my brother graduated by 19. So I had a role model. My brother was actually even faster. And what I did is I decided to do all my undergraduate in 3 years. I knew I wanted to go to medical school. And I figured that the sooner I got on the road, the better in a certain way. So I by going some summers and taking a little heavier course load, I was able to do everything in 3 years and graduate so that I could start and get into medical school. Because I knew pretty early on that I wanted to be a doctor, but I also had this love for research that I got even as an undergraduate.
And why chemistry?
Well, as I would probably comment later, but I'm always been strongly influenced by teachers or mentors that I've felt are impressive. And when I was an undergraduate, probably the professor who really most struck me was a guy named Tom Crawford, who was head of the Department of Chemistry at the University of Louisville. And he actually sort of fostered my early interest in research. He was doing early types of NMR spectroscopy, which was really pretty new at the time. And so as a chemistry major, I actually worked in the summers doing some research with him, doing NMR spectroscopy. And this was probably, in terms of courses, I had more or less the same amount of biology and other things, but chemistry was his specialty, and so I followed his lead.
All right. So it sounds like you knew fairly early on that you wanted to go to medical school, but did you have a fixation already on endocrinology as you went into medical school, or is that an interest that developed during your time there?
Yeah, so it's I would say fair to say that the fact that I'm an endocrinologist is almost happenstance. And that's partly because almost everything I tried, I liked, which is a fortunate thing to have. And because I was influenced by different people in my career, I thought about different areas of specialty. When I first graduated from medical school and started my internship and residency, probably my most influential professor at medical school was a gastroenterologist. So I thought, oh, I want to be a gastroenterologist. Then I went to Washington University Barnes Hospital for my internship and residency. And there were quite a number of very influential professors. In fact, in endocrinology, Dave Kipnis was a young rising faculty member. Bill Dowday, who was a famous endocrinologist, was co-chair of the Department of Medicine. But the person who actually influenced me most was a nephrologist, a man named Neil Bricker, who was head of nephrology. And so I thought, well, maybe I'll be a nephrologist. So how did I wind up in endocrinology? Well, it has to do with the NIH. And at that time, when you went to the NIH, you could go in an undifferentiated mode. You didn't have to say, oh, I'm going to be an endocrinologist or a nephrologist. You could interview based on the science, based on the research. And so I put down for my interviews people in nephrology and endocrinology and gastroenterology, the main areas, even cardiology areas that I thought about. And as I was meeting with them, it was also kind of a matching program. And I must say, being from Louisville was not a big advantage in this matching program. It was the Vietnam War era. Many medical students wanted to go to NIH in lieu of going into the service after they graduated. I also wanted to go, but I wanted to go because I knew I was really interested in research. And I didn't really have the connections, let's say, that the people at a Harvard or a Yale, being from the University of Louisville. So I got lucky in a way. I really got really lucky because my mentor at NIH, the person who I eventually matched with, was Jesse Roth. And Jesse Roth, I think you've also interviewed for this series, and he's also one of the great endocrinologists of the 20th century. But what was important for me about Jesse, besides him being an outstanding mentor, was he had a very interesting way of picking people to interview. His idea was to shop undershopped markets, kind of a merchant's idea of, if everybody's trying to buy at one place, maybe you'll get better merchandise if you try someplace else and not have to compete. And so while many of the people at NIH were limiting their interviews to people from Ivy League type medical schools or Stanford or UCSF, Jesse figured if I can get top guys from Louisville or from Ohio or from the Midwest, they'll probably hold up pretty well here. And so he and I matched, and that got me into endocrinology, and it's been a fit ever since.
After spending your whole life in Kentucky, what was it that made you decide to go to Washington University in St. Louis for your internship and residency? And what was that time like?
Well, WashU was actually had a kind of a good connection, I would say, with the University of Louisville. Several years before me, they had accepted some of the people who had graduated high in the class into the Department of Medicine. And so, because as you know, the internship and the residency matching programs were matching, and it was competitive again, it was one place where I felt that they had some respect in a way for people graduating from Louisville. They didn't sort of discount them. And so if you graduated at the top of the class or near the top of the class, then you had a pretty good chance of getting an interview. And it was terrific. Washington University was just an exciting place. It was an exciting hospital, Barnes Hospital. The house staff were really terrific. I had many people in my small group of interns and residents that were really also ultimately very successful in academic careers in different areas. But two names who were really important in endocrinology and diabetes were Phil Cryer, who has unfortunately passed away, was one of the residents when I was an intern. Phil's older than me, and also Joe Averick, who was a resident. And it was a few years ahead of me, but was also very influential. In fact, I have a very funny story, if I can tell it, about that period, because I think it's kind of, it's one of my favorite stories from that period. So I was an intern on female medicine. Then we had ward services, and the female ward and the male ward. So you were on female medicine. And Joe Averick, who eventually became head of diabetes at Mass General Hospital and a very distinguished endocrine diabetes researcher, was the resident. And it was December of that year, and it was we had a woman who was admitted from the emergency room unconscious in diabetic ketoacidosis. She had been found on the floor of her apartment. Nobody had any medical history. We didn't have any background, but she was in very severe diabetic ketoacidosis. Fortunately, it's very rare for people to die of diabetic ketoacidosis. People still do die occasionally, but at that time, it was still rare, but her ketoacidosis was very severe. Her pH was 6.7. She had very disturbed electrolytes. She had very hypotensive, almost unmeasurable blood pressure. She wasn't making any urine. And Joe and I got this challenging case. And we did all these things. We got her electrolytes right. We got her glucose down. But eventually, she still succumbed to her ketoacidosis. She never came out of this kidney failure and heart failure, and she passed away. And Bill Dowday, this giant of endocrinology, said, well, she should be a case for morbidity and mortality conference. These are conferences where you discuss cases that sometimes didn't go the way you expect. And in her case, she was the first person in 10 years to die of ketoacidosis at Barnes, so this became a teaching case. And Joe and I presented exactly what happened. And, of course, they said, well, why didn't you do this or do that? Because obviously maybe you could have tried something else. And at the end of the conference, Bill Dowday said, well, one thing we've learned from this conference for sure is that neither of you will ever make it in diabetes or endocrinology. And he went on to become the head of diabetes at Mass General, and I went on to become the head of the Joslin Diabetes Center. So I subsequently have seen Bill Dowday, or he's now also passed away, but when I did see him, I reminded him of this story. And he said, well, sometimes you don't get it exactly right.
I think that's a perfect example of where a patient and an experience may or may not even actually influence your trajectory, but given that you were treating patients and started off on a more clinical track, though, with a research interest, did you ever see any patients that either changed the course of your thinking about your research or the research track that you might end up taking?
Yes, this is really something I think that's important for MD investigators, and is in fact something that I also felt very fortunate that Jesse Roth was my mentor, because even though he was not that involved in clinical medicine, he also did clinical medicine during the time I was at NIH. And he always stressed something very interesting. We get a patient where might be let's say a woman who was having some sort of spells that they thought might be hypoglycemia, but weren't. And people would always say, oh, it's just psychological, or it's just something. And Jesse would go around and he would say, well, this patient has a disease. We just don't know the name of it yet. But if you can figure it out, this will be in the Harrison textbook of medicine in 2020, right? So these symptoms are probably real, and we just aren't aware of what is happening. And in our case, this was really important for the research, because we were interested in insulin resistance. And we were, in a way, collecting from around the United States patients that had been referred for very unusual and severe forms of insulin resistance. These patients were a range of ages, but mostly they were women or girls, and they had insulin resistance of a level that's sort of rarely seen in a clinical. These were patients that were taking thousands, and in fact tens of thousands of units of insulin a day. A normal replacement dose is 40 or 50 units, let's say, for an adult. And I had a woman who was taking more than, I actually had a patient where we were giving her 10,000 units of insulin intravenously an hour. So way up here. And eventually, as we try to understand these patients, we realized that there were two clinical syndromes here that were syndromes that we called the syndromes of insulin resistance and acanthosis nigricans. Acanthosis nigricans is a hyperpigmentation, hypergrowth of the skin. And we called them type A and type B. And eventually this became a New England Journal article, type A and type B insulin resistance syndrome. And type A turned out to be patients with genetic defects in the insulin receptor. And type B were patients that had autoantibodies to the insulin receptor and developed autoimmune mediated insulin resistance. The reason that this was so important was that at that time, we could only identify the receptor by insulin binding to cells, radioactive insulin binding, or so what we called a radioreceptor assay. We didn't have the protein. This was before cloning. We didn't have any tools that would be modern tools of biology. But we took advantage of these patients with autoantibodies to the insulin receptor, and we used those as the first way to probe the receptor for immunoprecipitation, for Western blotting, and ultimately to look even for the receptor tyrosine kinase activity that defined it as a member of the tyrosine kinase family. All of this information, the receptor structure, the fact that it had two different kinds of subunits of two sizes that formed a tetramer, that it was a tyrosine kinase that underwent autophosphorylation, all were learned using these patient antibodies before the receptor was purified, before the receptor was cloned, before we knew its sequence. So patients can provide unique insights both to disease pathophysiology and, in this case, a unique tool to actually study something in very basic biochemistry.
So you land with Jesse Roth, and this was just at the beginning of even his investigations into figuring out that insulin actually had a receptor as opposed to signaling through second messengers, et cetera. So what was that time like? And did you start out working on the insulin receptor?
So this is actually another interesting story. I might get in trouble with Jesse for telling it, but when I arrived at NIH, at that time I was called a clinical associate, and there were two clinical associates coming into his group every other year for a 2-year window was the initial commitment. And the other clinical associate who came in with me was a physician named Arthur Sober, who, and Jesse said, Bob Lefkowitz had just left the lab, and we had just, meaning me and Bob, had just done this preliminary paper on the ACTH receptor. And Jesse was very excited about the potential for the ACTH receptor, and he put both of us on the ACTH receptor, different aspects of trying to follow up on these studies. To make a long story short, we worked for 11 months without actually being able to make any progress on this. There were lots of technical issues. The cells had changed, a piece of equipment that was critical in the preparation had changed. We couldn't get a kind of reproducible result. And it was a little bit discouraging after 11 months of having this problem. Although others did reproduce the work, we couldn't get it to work. And so Jesse said, agreed that maybe we should change projects. I went on to join Pierre Fauché, who was then there to work on the insulin receptor, and Arthur Sober went to work on another project, eventually changed his complete specialty interest, became a very successful dermatologist at Mass General, doing academic dermatology. But I think that the moral here, and I think if people are listening to this for their sort of education about what life is like, is you go through periods, even long periods, where nothing seems to work right. And that doesn't mean that it will never work right. It's just, you have to give it, as I say, the good old college try, and then you have to be prepared to, at least for a while, move on to something else if it's not working. You can always come back to it, but this was a bit of a trial by fire to have a project that went so long and didn't work.
Right, and then I am assuming that some of the insights that you had came from these patients that you were just talking about.
Right. It was partly the clinical feedback. It was partly that obviously compared to problems with ACTH, problems with insulin action were really much more clinically important. And so it was clear that, if we could get the insulin receptor to work, that this would have even potentially greater opportunities, and it did. So I worked with Pierre early on to get the early studies going, to do some of the basic characterization. Then the patients came along. We also had animal models of disease, obese mice, then we quickly got into humans. So it was really a very, very exciting time. And it was for sure the kind of thing that cemented my interest both in diabetes and endocrinology, but really understanding insulin action, which has been the challenge of my lifetime.
So you began by saying that you got there for this 2-year clinical research fellowship, but you stayed for 9 years. So why did you stay?
Yeah, actually, I wound up staying for a total of 11 years. Although I got 1 year off for good behavior, I did a sabbatical in France while I was at NIH, and then came back to NIH for a year. Then I moved up here to Boston. And the reason I stayed was really in large part driven by the research, which was so exciting. Not only was Jesse a terrific mentor, but Phil Gordon was his co-section head, co-branch chief at one point. And Phil Gordon eventually also became the director of NIDDK, so he was very influential in my life as well. He was more interested in the clinical problems of insulin resistance and endocrinology, but they were this terrific balance. Jesse was a kind of hard-driven, dynamic New Yorker who was really interested in the basic. Phil Gordon was a much more soft-spoken, Southern, little bit sort of laid back in his approach to things, but just as smart and just as insightful. And this was a great environment to be in. So, so it was really a truly special time.
What, after the 11 years at the NIH, what prompted you to consider moving to Harvard and the Joslin?
I think that there were a couple of things that really made me feel like it would be good to take on the challenge of the Joslin. One is, at the time, the diabetes branch had 2 senior leaders, Jesse and Phil, both of whom, as far as I knew, might stay doing that forever. And in general, research groups at the NIH are small, particularly in NIDDK, they're quite small. So I didn't see necessarily an obvious coming opportunity for me to become head of the diabetes branch or some other branch, for example. And I did like the idea of being able to grow. The Joslin was at a very challenging time in the research area, particularly because George Cahill, who had been head of research at Joslin through most of the 60s, or much of the 60s and 70s, had left Joslin to become an associate director of Howard Hughes Medical Center. And Joslin was left with kind of no apparent leader. I mean, there were some people there, but none of them really were identified as being potentially the candidate for the director position. So it was a challenge. People actually said, "Oh, this is going to be really challenging," because the faculty. When I got to Joslin, there were literally 5 people on the faculty in the research division, and one of them left. So then there were 4 plus me, now 5 again. So it was very small, but clearly it had the potential to grow and to become a really more important part of diabetes research and a more important part of the Harvard medical environment. So I took on the challenge.
It's always struck me that people who are truly hitting their academic stride then are given more and more leadership responsibility and recruitment responsibilities and administrative burdens. So how did you balance those things with what was an amazing upward trajectory? Because I remember reading from your CV that it was around this time that you started to pick off things like the fact that the insulin receptor was a tyrosine kinase receptor, started to identify IRS1 and 2. So how did you balance all of these things at that same time?
Well, when I first got there, as I mentioned, the research division was small. And my major job was to recruit, to try to build it up. Obviously, I had to wait till resources became available or help work to get some of the resources to be available. So this allowed me two things. It allowed me, one, to focus some significant amount of time on my own research, but it also allowed me to try to populate the Joslin with other investigators who would also be good scientists. And being in a stimulating environment, even if it's not focused exactly in your area, but people who think about biomedical science and physiology was really a way to help grow my own career in a certain way, as well as grow the Joslin. So it was really good. During that time, I recruited George King, who had come with me from NIH to become an independent investigator at Joslin. I recruited George Eisenbarth, who became the ultimate leading person in type 1 diabetes autoimmunology of that era. Recruited other people in other areas, Bill Chin in molecular biology, Diane Mathis and Christophe Benoit in immunology. So we recruited some people who were just very, very exciting. And also people doing clinical research, Andrzej Karlewski doing epidemiology, and others. So this really was a way to grow this research activity. And I was able to keep my own research very focused. The hard part came when I became president, CEO of Joslin. Then I had to be, I would say, more disciplined about how to spend my time. One trick I learned is to put my fellows' meetings on my calendar just like they were any other appointment, because then my secretary at the time wouldn't double book me. She wouldn't put other meetings there. If I left them off and just try to do it ad hoc, my calendar would instantly get filled up. But I felt that this was really a good synergy. So I actually liked the challenge. Of course, it required a lot of time and effort to do all of this. But for me, it was a good, energizing experience, I would say.
What is your opinion about where you see the field of metabolism going over the next 10 to 15 years?
The interesting thing about science, or one of the interesting things, is the way every field has its kind of ups and downs. It becomes fashionable. Everybody is into neuroscience now because of Alzheimer's disease and all the interest in that. Everybody a few years ago was focused on autoimmunity because of its implications and so forth. Metabolism is old science in a way. Certainly, it's an old, metabolism was recognized not as early as anatomy, but it was recognized certainly, a couple hundred years ago. And I remember I have to say that Ben Lewin was the first editor of Cell, the founding editor. The first time I sent a paper to Cell, it got rejected without review. And the criticism was metabolism is old science. We want to publish in this journal new science, like neuroscience and C. elegans research and things like that. But I think everything sort of comes around. And metabolism, of course, now is at the heart of cancer biology. Some of the greatest studies going on in trying to develop new therapies for cancer depend on understanding cancer metabolism. The microbiome, which is so hot in gastroenterology, is really in many ways a lot about metabolism, because microbes are another organ that are metabolizing our substrates, that are feeding us different kinds of nutrients that are occurring in the diet that might positively or negatively affect us. So I think that metabolism has worked its way into many other areas. CNS metabolism and its relationship to Alzheimer's disease, potential role of even insulin action. Where is it going to go? I think that that there's a surprising amount we still don't know. I think that the worry of many young people coming into a field is, oh, all the interesting questions have been taken. All the easy stuff has been done. What's left is neither very interesting nor very easy. It's just the details. But that isn't true. It really isn't true almost in any field. And it's certainly not true in the diabetes field. We've learned a huge amount about insulin action and insulin resistance. But if you ask me to sort of honestly say, do we know the cause at a molecular level or a genetic or cellular level of the insulin resistance underlying type 2 diabetes, a disease that affects 30 plus million people in the United States alone? I'd say the answer is we still don't understand it. We still don't have it. So we're going to have to take new ways of looking at problems. We have to keep an open mind. And this is something that I try to really stress a lot to my own fellows. It is part of my training of them, is that they have to kind of look beyond the data, look at the data, and then think beyond what's in the literature, think beyond the classical paradigms, and try to say, if you didn't know anything, what would you think? Start fresh, take a fresh look. I think metabolism will have many new twists. There are going to be new hormones. There are going to be new forms of communication between cells that are, in a way, intracellular communication, and between cells, intercellular communication. But it is not a classical hormone. For example, we're working on exosomal microRNAs being secreted by one cell, being taken up by another cell, and regulating gene expression. And I think there are going to be a lot more things like this. So I think there's great opportunity there, and it works its way into so many fields.
There was something that you just mentioned in there that brings up a different question, which is you talked a little bit in that last reply about the way you talk to your fellows and you teach the people in your group. So what is your approach to mentoring?
Well, mentoring is one of the most important aspects of both my job, but it's also been an important aspect of my life. And I start out by telling all of my students and fellows and that you really need mentors all along. That mentoring is both important to learn how to do, but it's also important to learn how to receive. One of the things that I learned through my own career is also that you have to find what I'll call it the sweet spot of each of your mentors is, and learn about his or her expertise, how they approach it. Jesse's sweet spot was being able to think outside the box, but think expansively outside the box, with almost no limits of, if we discovered autoantibodies to the receptor in an insulin-resistant state, he immediately wanted to know, well, maybe autoantibodies are the cause of manic depressive illness, and we have stimulating inhibiting. So it would be, don't worry about just your little field, think big. And that's one of the things I really try to encourage my own fellows to do, is to not be limited by what you read in a textbook, not feel like your data has to fit. You have to put this shoe on and make it fit. But rather the goal idea is to try to use it to expand the knowledge base. And so I spend a lot of my time with fellows looking at data, not because I actually don't trust them to look at the data themselves and sort of report it to me, but because I realize that most of them during their training have this tunnel vision. If they're looking at a gel and it has a band that's the insulin receptor, they always say, well, you see the insulin receptor band went up or down or didn't change. And I always say, but what about this other band here on the gel that goes way up or way down? What is that? They said, well, I don't know. I just wasn't paying any attention to that. So I think it's just keeping this open mind, and that's something I really do. I'll say one or two other things about mentoring that I think are important. I think that as scientists and physician scientists, we need to teach our fellows to be able to write well and to be able to speak well, because communication is really the way you can make your science felt and heard. And if you have a great discovery and you can't write about it well and you can't speak about it well, this is certainly not going to work out to make it either well appreciated or to help your career. So we spend a lot of time learning presentation style, learning how to decide what data gets put together with what data so that you could actually tell a story that somebody can remember, and that you yourself see the connections. You yourself see that, oh, it could go this way or that. And it doesn't have to be a story that matches the literature. It has to be a story that makes sense based on the data.
Well, clearly you've excelled at that. In looking at your CV last night, I noted over 680 research articles, many of which are in the JCI, and
Right.
over 200 opinion pieces. So I think you were in the lead for the most number of articles in the JCI until I took over and have been using it as my bully pulpit.
Yeah, I think I'm second to you only in papers in the JCI. I love the JCI still as a journal because I love the fact that it's not a specialty journal. And I love the fact that it publishes good science in many different fields. And so I still encourage my fellows frequently, for example, if you get PhD fellows, they're not that familiar at all with the journal. And even a lot of MD fellows don't recognize it, But I think that, there's obviously a lot of other excellent journals, but JCI is one of my favorites.
Glad to hear it. All right, I'm going to end with a question that I always ask of all of the subjects that I've gotten a chance to interview, related to what kind of an alternative career you might have had if you wouldn't have been a clinician or a scientist. But before I let you answer, I want to pre-prompt you by reading an email that I got from you in January of 2012.
Okay.
After we had had a chance to catch up at a Keystone meeting. So you said, and I quote, "The dinner at Coyote Cafe was by far the best meal I had in Santa Fe, and the company made it even better. We would certainly make a great political team, but I don't think America is quite ready for a Jewish president and an Indian American vegetarian vice president. So what do you think, Ron? Should we be running in 2024? I hear Indian vice presidents are all the rage these days. So
Yeah,
would politics ever be in your future?"
We were definitely ahead of the curve with that idea of having the Indian vice president. But you could be the president, and I'd be happy to be your vice president. I think personally, it would be hard, even though I've liked leadership positions. In some ways, I think politics is probably not where I would put my first choice. Although one time I thought, being president would be a great job. But I think probably if I had to say, obviously I love doing science and I love doing what I'm doing. But I think that if you have a passion, you can be so happy doing many things. I think the people I'm most envious of in terms of their job is who, if I could steal somebody's talent and have another job, it would be to be a musician or a singer. I love music in all forms, just about. I play a couple of 3 instruments, not very well. I can't sing worth a darn because I unfortunately have the genetics of a bad voice. But I think that form of professional activity, if you're really good, to be a Yo-Yo Ma or Yitzhak Perlman or a virtuoso singer who has a great voice, Pavarotti or something like that. It must be so wonderful to be able to do something that not only gives you pleasure, but gives so many people pleasure when you do it. So I think that would be my secret passion. But unfortunately, I just don't have the talents to make that passion come true. But I think we can still run. It's only, we're still in August and the election isn't for a couple of months. So maybe we should sharpen up our pencils and be write-in candidates.
We were just ahead of our time, Ron.
Definitely.
Well, listen, thank you so much for taking this hour to chat with me. We've been friends for a long time. I've been one of your biggest fans for a long time, and I'm thrilled to have had a chance to hear a little bit more about the way that you think and how you grew up. So thank you so much for sharing your thoughts with us.
Oh, and thank you for choosing me for one of these interviews. It's been fun.